Every second of every day, an older adult falls. Falls and fall-related injuries are common and have consequences for older adults. I'm Susie Stark from Washington University. I'm an occupational therapist, and I want to talk today about falls and fall prevention for older adults. About a third of community-dwelling people over 65 years of age fall each year, and the rate of fall-related injuries increases with age. Around 10 to 20% of falls result in an injury. Falls are the leading cause of hip fracture, the leading cause of traumatic brain injury. They are more common than stroke and more serious in functional consequences in many situations. Fall injuries in older people are a significant source of morbidity and mortality and are an independent predictor of nursing home admission. Fear of falling and loss of confidence can result in other consequences, including self-restriction of activity levels. This can impact on strength and balance, contributing to frailty, where the person does not have the physical reserve to perform their daily activities. Both injurious and non-injurious falls can have these psychological and subsequently physical effects. Surviving an injurious fall is costly. It's estimated that the consequences of falls cost about $50 billion in US dollars annually, with at least $12 billion of those dollars coming from private pay or out of pocket. There are even greater costs to society. Fall death rates continue to rise in the US. In this chart, we see the increase from 2007 to 2016 in fall death rates in the US. As we continue on this trajectory, we can anticipate 7 fall deaths every hour by 2030. If we know that about 1 in 3 or 1 in 4 older adults is going to fall every year, I think it's important to realize that about half of those falls occur in an individual's private home. What's important also to realize is that about 9 out of 10 homes don't have the kind of supports that older adults need to stay at home and age safely. But about 89% of older adults tell us they fully intend to stay at home and age in place. Most adults do live at home. About 90% live in single-family homes or apartments. Only about 4% of older adults actually live in places like nursing homes. 50% of those older adults have lived in these homes, many for over 25 years, and about 1/3 live alone. Epidemiological studies have identified a number of risk factors for falling in the community. It's estimated that about 60% of falls come from multiple causal factors, and about 1/3 are attributed to just environmental causes alone. Extrinsic or environmental fall-related risks include environmental factors such as slippery or uneven surfaces, clutter, poor lighting, selecting poor footwear, step hazards, unsafe rails, or loose mats. Behavioral risk factors can include things like rushing, not paying attention to the path ahead, or poor lighting. Intrinsic factors, things that are unique to each individual, are another set of fall risk factors. Some of these are modifiable, some are not. They include things like your age, a history of previous falls, using an assistive device to walk, difficulty with activities of daily living, slower gait speed, poor balance, dizziness, fear of falling, urge incontinence, comorbidities, vision impairment, chronic diseases such as Parkinson's disease, depression, or dementia, a history of stroke, polypharmacy or taking 4 or more medications, or foot problems. These factors can modify the way an individual engages with their physical environment. These factors can change each individual risk for each person. For example, about 1/3 of people 65 or older are going to fall in the community, but 50% of people who are 80 or older will fall each year. So what can we do to prevent falls? There's a strong justification for targeting home hazards for fall prevention. Remember, 50% of falls occur in the home, and about 1/3 of them are related to some type of home hazard. There's strong evidence that home hazard removal can reduce falls by about 40% for older adults at high risk for falls. Home hazard reduction includes the process of providing an assessment of the person and their environment, reducing the hazards in the home, and raising an individual's awareness of their own fall risks. Solutions that focus on hazard reduction usually do not involve major structural changes. The intervention does include a comprehensive evaluation of the environment and the hazards in the home, priority setting that takes into account the personal risks of the individual, and an assessment of the person's real home environment. The use of an assessment tool that's validated for the broad range of potential fall hazards the individual might encounter. The inclusion of formal or observational evaluation of the functional capacity, the physical, behavioral, vision, sensory assessment of the person within the context of their environment, the provision of adequate follow-up and support for providing these modifications and removing home hazards, and the active involvement of the older adult in the assessment and priority setting of fall hazards. Today, we'll be talking about one such program called HARP, which stands for Home Hazard Removal Program. HARP is delivered by occupational therapists in the home of older adults at risk for falling. HARP includes two distinct elements: modifying behavior and also removing hazards in the home, modifying the environment. The two modifiable risk factors that we know we can address to reduce falls. Two important elements that we include in this intervention are tailoring to make sure the intervention meets the needs of the individual, and that it's client-centered. That is, that the person is on board and supportive of the types of changes that we recommend. The treatment theory guiding this intervention is the ecological model. The idea is that if we reduce the press of the physical environment to match the abilities of the older adult, we can reduce their fall risk. Observational studies show that the mere presence of a hazard is not associated with falling. Rather, it's the interaction between a person's abilities and the environmental hazards that poses a risk for falls. HARP includes 2 to 3 initial treatment sessions, during which an occupational therapist systematically evaluates an older adult's abilities and the barriers in their home, and develops an intervention plan that removes the home hazards and also provides behavioral strategies to teach older adults self-management to reduce their own fall risk going forward. The therapist then comes back 3 to 6 months later to provide a booster session to address any new problems that might have emerged since the initial treatment. HARP is evidence-based. We conducted a study with the St. Louis Area Agency on Aging, and in a randomized controlled trial, we discovered that older adults that received the HARP intervention had 40% fewer falls than the group that received usual care. We are hoping to find occupational therapists willing to join our HARP team. Please join us. We hope you enjoy these videos.